Andrea Wolf here, and this is a discussion of the renal and urologic system, its physiology and pathophysiology. So we'll start with an overview of the functions of the kidney, and the primary functions are to maintain a stable internal environment so that you can have optimal metabolism in the body, to balance the solute and water transport, to excrete waste products, to conserve what the body needs, the nutrients, and to regulate acids and bases. And the kidney has endocrine functions. It secretes hormones, and those hormones are renin for the regulation of blood pressure, erythropoietin for the production of our red cells or erythrocytes, and the metabolism of calcium is also regulated by vitamin D3, which is secreted by the kidney as well. The kidney performs gluconeogenesis, so that is synthesis of glucose from the amino acids in the liver, and it forms the urine. And here you see a review of the anatomy of the kidney. The kidneys are located in the retroperitoneal area behind the peritoneum. They're surrounded by a capsule, and the fibrous tissue or fascia attaches the kidneys to the abdominal wall. That's called the renal fascia. And in the hilum of the kidney is where the nerves, the vessels, the lymph enter and exit the kidney. Here we see the renal cortex, the medulla, and the columns. Here we see the minor and major calyces and the renal pelvis. So the major calyx joins to form the renal pelvis, and the pelvis joins the proximal end of the ureter. The nephron is the functional unit of the kidney, and it's a tubular structure that has subunits that include the renal corpuscle, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct. All of these contribute to the formation of urine. And the different epithelial cells that line various segments of the tubule facilitate the special functions of either reabsorption or secretion. So the nephron has its main functions in reabsorbing water and electrolytes and other substances, and secretion of the unneeded compounds that will be eliminated from the body. So kidney is able to maintain a constant glomerular filtration rate, or the GFR. And the glomerular filtration membrane filters the blood components through its three layers. There's an inner capillary endothelium, a middle glomerular basement membrane, or the GBM, and an outer layer, the visceral epithelium, which forms the inner layer of the Bowman capsule. And the glomerular filtrate passes through these three layers and forms the primary urine. And the kidney is able to auto-regulate. We call this renal autoregulation. So this is because of the hormonally mediated adjustments in the afferent and efferent arterioles. The glomerulus is supplied by the afferent arteriole and drained by the efferent arteriole. And regulation of renal function, as I said, is hormonally mediated through changes in the resistance of the afferent and efferent arterioles. So within the glomerulus, blood supply comes in through the afferent arterioles and goes out through the efferent arterioles. And then there's Bowman's capsule, and it's composed of cells called podocytes. And that forms an elaborate network of the clefts called filtration slits, and that modulates filtration. So here we can see what's happening with glomerular filtration. The initial filter is the glomerulus for blood entering the kidney. And this is where we actually see immune complex deposition and complement fixation. So in some diseases, such as glomerulonephritis, there are immune complexes that form within the glomerulus, causing the inflammation and all the problems related to that. So from the Bowman's capsule, the filtrate moves into the tubular segments of the nephron, and as it moves through the tubule, it simultaneously reabsorbs and secretes in the peritubular capillary and in the tubule, secretion in the tubule. The juxtaglomerular apparatus is made up of the juxtaglomerular cells, which are renin-releasing cells, and the macula densa, which are the sodium-sensing cells, and the whole juxtaglomerular apparatus controls renal blood flow, glomerular filtration, and renal secretion. In the proximal tubule, the functions there are the reabsorption of substances such as glucose, amino acids, lactate, water-soluble vitamins, and secretion, such as substances such as urate and oxalate, organic compounds, and drugs, such as penicillin, aspirin, and morphine. The loop of Henry has its major function in concentrating the urine. So 20 to 25% of the filtered load of the sodium, potassium, and chloride is reabsorbed here. So the distal tubule is where aldosterone has its effect. Calcium is reabsorbed here, and the sodium-potassium ATPase pumps the sodium into the blood and potassium into the urine in the filtrate. The collecting tubule is where ADH, or antidiuretic hormone, has its effect, so it can change the permeability of the tubules and the duct, and it's released in response to an increase in serum osmolarity. Here is a summary of all the major functions of the segments of the neuron, what's going on in the tubule, the proximal tubule, the loop of Henry, the distal tubule, and the collecting duct. So characteristics of the normal urine include that it should be clear, amber-colored fluid, as we know. 95% of it should be water and 5% dissolved solids. The kidney normally produces about 1.5 liters of urine each day, and it contains metabolic waste and few, if any, plasma proteins, blood cells, or glucose molecules, at least when things are going normally. Obviously, all that changes when we have dysfunction. So elimination functions of the kidney are to regulate the amount of sodium that's eliminated, the amount of potassium that's eliminated, organic compounds that are pH dependent, uric acid and urea elimination, and drug elimination. Certain drugs, as we know, are eliminated here in the kidney. So going back to the endocrine functions of the kidney, we have the renin-angiotensin-aldosterone mechanism. So in response to low sodium or decreased perfusion, the kidney releases renin, and that is a very potent vasoconstrictor. And in response to tissue hypoxia, such as anemia or when people are at high altitude and they need more oxygen carrying capacity, it will release EPO, or erythropoietin, which causes erythropoiesis or production of RBCs. In response to parathyroid hormone, the kidney can release vitamin D, which increases calcium retention and causes phosphate wasting. Now some of the structures of the ureters and bladder. During micturition, there's compression of the lower end of the ureter, and that prevents reflux of urine. So the ureters are 30 centimeters long, give or take, and they're composed of smooth muscle bundles that pass obliquely through the posterior aspect of the bladder, and it's peristaltic activity that moves the urine through to the bladder. Here you can see the bladder and its detrusor muscles, the transitional epithelium, and the trigon of the bladder. In the urethra, you see where the internal urethral sphincter and external urethral sphincter lie. And these are smooth muscle that control the release of urine from the bladder. So the bladder is innervated. The innervation of the bladder and the internal urethral sphincter is supplied by parasympathetic fibers of the autonomic nervous system. And these come from the sacral levels of S2 to S4 of the spinal cord. And they contribute to bladder contraction and urine emptying. And then the sympathetic fibers that come from the T11 to L2 levels of the spinal cord inhibit the bladder body to retain urine, and the proximal urethral sphincter to retain urine. So here you can see that when the bladder is stretched as it becomes full, that fullness is sensed and impulses go to the sacral level of the spinal cord. And then when the urine accumulates to between 250 to 300 milliliters, contraction occurs, and that's voiding. We'll start the discussion of abnormalities with urologic disorders. You can have urinary tract obstruction, which is blockage of urine flow from the urinary tract. And obstruction can be caused by obstructive uropathy, whether there's an anatomic or some kind of functional defect. Severity, it depends on where it's located, how complete the obstruction is, whether it involves the upper, one or both upper urinary tracts, how long it's been obstructed, and what the underlying cause is. So for upper urinary tract obstruction, strictures is a cause, can be a cause, kidney stones, compression from a tumor, or some kind of abdominal inflammation that leads to scarring and causes compression that way. And then in the lower urinary tract, that's going to be caused by a neurogenic bladder or an anatomic obstruction. Lower urinary tract obstruction is related to storage of urine in the bladder and emptying of the bladder through the bladder outlet. So if there's something that causes bladder outlet obstruction, that would be a lower urinary tract obstruction. So it can be neurogenic, anatomic, or both, and it causes the symptom of incontinence. These are some complications of upper urinary tract obstruction. For example, in a kidney stone, you can have a hydroureter where there's dilation of the ureters, hydronephrosis, where there's dilation of the renal pelvises and the calyces, ureterohydronephrosis, which is dilation of both the ureters and the renal pelvis and calyces. You can have tubulointerstitial fibrosis, where there's deposition of excessive amounts of extracellular material. And it can lead to, all of these can lead to an excess cellular destruction and death of the nephrons. So that's why it's really important to determine when someone has a renal stone to determine whether any of these complications are at play, like a hydroureter or hydronephrosis, because of the kidney damage that can occur. So renal calculus formation is complex, and it's related to supersaturation of one or more salts in the urine, then precipitation of those salts from a liquid to a solid state, forming crystals, and then growth through crystallization or what's called agglomeration or aggregation. And supersaturation is the presence of a higher concentration of a salt within the fluid, in this case the urine. Then higher concentration, then the volume is able to dissolve to maintain equilibrium. So human urine contains many positively and negatively charged ions that are capable of precipitating from a solution and forming a variety of salts. So the salts form crystals that are retained and grow into stones. So this shows the different stones that we can have. We can have calcium stones, oxalate or phosphate, struvite, which are comprised of magnesium, ammonium, or phosphate. Uric acid stones, we see that in gout or in patients that have high purine diet and in dehydration. And then cysteine stones, which tend to be hereditary. And calcium stones account for 70 to 80% of all the stones that require treatment. Now I'm going to move on to renal disorders. I'm going to start with a discussion of how we classified kidney dysfunction. So kidney injury may be acute and rapidly progressive within hours, and the process may be reversible. It can also be chronic, progressing to end-stage kidney failure over a period of months or years. The term renal insufficiency, renal failure, uremia, and azotemia are all associated with decreasing renal function, but they're not specific in relation to the cause of the kidney disease. So generally, renal insufficiency refers to a decline in renal function to about 25% of normal, or a GFR of 25 to 30 milliliters per minute. And the levels of serum and creatinine and urea are only mildly elevated. But in renal failure, you have significant loss of renal function, and when less than 10% of the renal function remains, this is termed end-stage kidney disease. So this is showing uremia versus azotemia, and uremia, or uremic syndrome, is a syndrome of renal failure and includes elevated blood urea and creatinine levels, and accompanied by symptoms of fatigue, anorexia, nausea, vomiting, pruritus, neurologic changes. It represents numerous consequences related to renal failure, including retention of toxic waste, deficiency states, electrolyte disorders, immune activation, promoting a pro-inflammatory state. Azotemia is characterized by increased serum urea levels and frequently increased creatinine levels, so normal being 0.7 to 1.4. Renal insufficiency or renal failure causes azotemia, and both azotemia and uremia indicate an accumulation of nitrogenous waste products in the blood. That's a common characteristic that explains the overlap in the definitions of terms. So with either one of those, you have an increase in the blood urea nitrogen in the blood. Acute kidney injury is a condition where the kidneys fail to remove the metabolic end products and to regulate the fluid, electrolyte, and pH balance of extracellular fluids. So this is also can be called acute renal failure. So it's an acute kidney injury that is abrupt in nature and often reversible. But there's a precipitous decline in the GFR over a period of hours to days. So it occurs rather rapidly due to some insult to the kidney. And you need to consider so this shows the pathophysiology of acute kidney injury. So it commonly results from extracellular volume depletion, which then causes decreased kidney flow, or renal blood flow, that is, or toxic inflammatory injury to the kidney cells that results in alterations in renal function that may be minimal or severe. Even small changes in the renal function can be associated with significant morbidity and mortality. So it can be in three categories. The etiologies of acute kidney injury, three categories: renal hypoperfusion, which is prerenal AKI, disorders involving the renal parenchyma and the interstitial tissue, as I said before, which is an intrarenal or intrinsic AKI, and then disorders associated with obstruction of the urinary tract, postrenal. And most types of acute renal injury are reversible if diagnosed and treated earlier. But you can see in each of these what happens in each case that eventually leads to oligoria, decrease in GFR, and then oligoria. So as I said before, prerenal causes are the most common form of kidney injury. Poor perfusion can be caused by hypotension, hypovolemia associated with hemorrhage or fluid loss, for example, in burns, sepsis, inadequate cardiac output, such as what happens in myocardial infarct, multiple organ dysfunction, anything that causes renal vasoconstriction, for example, NSAIDs or radiocontrast agents, renal artery stenosis or kidney edema that restricts arterial blood flow. And in the early stages of hypoperfusion, there are protective autoregulatory mechanisms that maintain the GFR at a constant level. But then as time goes on, those systems decompensate. There are tubuloglomerular feedback mechanisms that also maintain the GFR and the distal tubular nephron flow. And the GFR ultimately declines because of a decrease in filtration pressure. And then the body decompensates. The kidneys decompensate. Intrarenal causes, as I mentioned, ATN, glomerular nephropathies, acute interstitial necrosis, renal artery or renal vein occlusion, if there's a bilateral acute pyelonephritis, and nephrotoxins such as aminoglycosides or that contrast media that we're very much aware of when we are imaging patients. So in acute ATN, or acute tubular necrosis, it's generally described as post-ischemic or nephrotoxic, or it can be a combination of both. And the terms acute tubular necrosis and acute kidney injury are sometimes used interchangeably, but the conditions are not the same because acute kidney injury can occur without ATN. So that's something just to be aware of in terms of terminology. So post-ischemic ATN involves persistent hypotension, hypoperfusion, hypoxemia that produces ischemia with a loss of the protection that causes cell swelling, injury, and necrosis. So there's a loss of antioxidants protection, I should say, that causes the cell to swell and to cause injury and necrosis. So there's activation of inflammatory cells, the neutrophils, macrophages, and lymphocytes, and also activation of complement and inflammatory cytokines that contribute to tubular injury. And so you get the appearance of a tubular granular cast in the urine. So whenever we see casts in the urine, we know that there's quite a bit of inflammation and damage to the tubules. Clinical manifestations can include fatigue, malaise, loss of ability to excrete water, salt, and waste. Patient will become dyspneic with orthopnea, crackles, an S3, and peripheral edema. And then the symptoms related to loss of renal water and salt secretory capacity that leads to various electrolyte disturbances and altered mental status. Diagnostics will look at the BUN and creatinine ratio, and we'll see a rise in the ratio as well as the absolute increase in the serum creatinine, and then eventually a reduction in urine output. Urinalysis will show sediments such as granular casts and other cells that occur in prerenal azotemia, and sometimes this occurs in obstructive uropathy. Now moving on to chronic kidney disease. That tends to develop more slowly, usually over the course of a number of years. And unfortunately, the incidence and prevalence of this is rising because of the diseases associated with chronic kidney disease, such as diabetes, hypertension, cardiovascular diseases, and of course that has to do with our lifestyle, the rising obesity in the nation. So in the US, about 20 million or 1 in 9 have chronic kidney disease. And in all forms of chronic kidney disease, there is a reduction in the functioning of nephrons. So the rate of nephron destruction varies depending on what the underlying cause is. So there's a progressive loss of renal function associated with the systemic diseases that are the underlying causes. And there are guidelines or practice guidelines called Kidney Disease Improving Outcomes Practice Guidelines. And they use the GFR and albuminuria as an estimate of the level or stage of chronic kidney disease. And that's beyond the scope of this course, but Um, it is, we do look at those parameters carefully when we're determining how to treat a patient, whether they're in stage 1, stage 2, stage 3, etc. So the clinical manifestations do not occur until renal function declines to less than 25%. So it's a much more insidious onset. Top three causes: diabetes, hypertension, and glomerulonephritis. But also we see this chronic kidney disease and polycystic kidney disease, obstructions of the urinary tract, cancers, autoimmune diseases, other diseases of the heart or diseases of the lung, and chronic use of pain medication is another cause of CKD. So let's look at some of the pathophysiology, the changes that are occurring in CKD. So initially, sodium and water balance is maintained because the water can increase the excretion of sodium and increase thirst. The plasma sodium concentration is typically normal, and hypervolemia is infrequent unless there's the dietary intake of water or sodium is really restricted, or whether it be excessive. There's deficient erythropoietin production, so we start to see an anemia, and disturbances in potassium balance because approximately 90% of potassium excretion is through the kidneys. We see decreased calcium, and that can cause to renal osteodystrophies, hyperphosphatemia, acid-base balance, metabolic acidosis being common, disturbances in protein, carbohydrate, and fat metabolism. So you get a negative nitrogen balance, and the serum protein decreases, and glucose intolerance develops. And then there's a high ratio of low-density lipoproteins and high triglycerides. The effect on the cardiovascular system is causing left ventricular hypertrophy, cardiomyopathy, ischemic heart disease, also arrhythmias, hypertension. The patient is volume overloaded. The pulmonary system can cause pulmonary edema, so you get dyspnea and cuspal respirations. Hematologically, anemia because of the lack of erythropoietin, a normocytic, normochromic anemia, which eventually can become hypochromic, hypocytic anemia. But generally we see a normochromic, normocytic. And then impaired platelet function and hypercoagulability. There are other effects too on the reproductive, GI, immune, and neurologic systems, which I won't discuss here. And deterioration of the kidneys can be accelerated by other insult added to injury, urinary tract infections, NSAIDs, uncontrolled blood pressure, uncontrolled blood sugar, continued smoking. So these are the things that we can do to try and offset the progression of chronic kidney disease, is to make sure we don't add insult to injury, have patients avoid NSAIDs, treat urinary tract infections as soon as they are detectable. Really trying to get good control of the blood pressure and blood sugar, and of course this involves careful monitoring and meticulous treatment, but also an attempt to try and get people to change their habits. And smoking, of course, is certainly going to continue to deterioration. Another thing that we need to target in our education and treatment of patients. This algorithm shows the progression in the mechanisms of progression of chronic kidney disease. And two factors that have been consistently recognized to advance renal disease are proteinuria and angiotensin II activity. So glomerular hyperfiltration and increased glomerular capillary permeability can lead to proteinuria. And that contributes to tubulointerstitial injury by accumulating in the interstitial space, and also by activating complement proteins and other mediators in cells, such as macrophages, that then go on to promote inflammation and progressive fibrosis. Angiotensin II activity is elevated with progressive nephron injury. So that angiotensin II promotes glomerular hypertension and hyperfiltration caused by efferent arterial vasoconstriction, and it also promotes systemic hypertension. The chronically high interglomerular pressure increases the capillary permeability in the glomerulus, and that contributes to proteinuria. And angiotensin II may also promote the activity of inflammatory cells and growth factors that participate in tubulointerstitial fibrosis and scarring. So now I'm going to talk about glomerulonephritis and nephrotic syndrome. And this disorder is caused by the changes in the glomerulus, which is associated with hematuria, proteinuria, a reduced GFR, and hypertension. So what we specifically see is hematuria, which we don't see in chronic kidney disease, causes of chronic kidney disease. But here we have hematuria as well as proteinuria, a reduced GFR, and hypertension. And the many different causes of glomerular disease can be divided into three major syndromes: nephrotic syndrome, nephritic syndrome, and asymptomatic renal disease. So in all causes of nephrotic syndrome, there is a structural abnormality where there's diffuse fusion of the foot processes of the podocytes in the kidney. And etiologies could be primary renal disease, where there's what's called a focal segmental glomerular sclerosis, because you have cellular changes that lead to sclerosis. And that's the most common cause of nephrotic syndrome in patients under 40. And then membranous nephropathy is the most common cause in Caucasian adults and those greater than 60 years. And then minimal change disease is another primary renal disease causing nephrotic syndrome. Systemic causes are diabetes, amyloidosis, lupus. And the incidence of nephrotic syndrome increases with age, and men greater than women are affected. So nephrotic level proteinuria is 3.5 grams or more of protein in the urine. The protein excretion is because of the glomerular injury that has occurred. And what we see is hypoalbuminemia, so low albumin in the blood, peripheral edema, and hyperlipidemia. So the pathophysiology of nephrotic syndrome are that it starts with disturbances in the glomerular basement membrane that leads to increased permeability. And then the plasma proteins, particularly albumin and some of the globulins, are affected. Albumin is lost in the greatest quantity. And the loss of plasma proteins decreases the plasma oncotic pressure, and that results in edema. Hypoalbuminemia results from the loss of albumin in the urine combined with the diminished synthesis of replacement of albumin by the liver. Decreased intake in the diet of protein from anorexia or malnutrition or accompanying liver disease may also contribute to lower levels of plasma albumin. Decreased plasma volume causes increased aldosterone and ADH, and that causes sodium and water retention, which results in edema. The loss of albumin stimulates lipoprotein synthesis by the liver, and that causes hyperlipidemia that promotes progression of glomerular disease. So it's a vicious cycle. Also, the loss of immunoglobulins that occurs increases susceptibility to the patient to infections. And then the patient also is in a hypercoagulable state as a result of alterations in coagulation factors, fibrinolysis, and platelet function. In nephritic syndrome, you will have hematuria, but that's usually microscopic. And there also will be red blood cell casts in the urine, in addition to proteinuria. And the proteinuria is not as severe as what you see in nephrotic syndrome. And that's caused by increased permeability of the glomerular filtration membrane, where the pore size is enlarged, and then red blood cells and protein can pass through. So difference in the nephrotic versus nephritic syndrome. In nephrotic syndrome, you're going to see massive amounts of proteinuria. Protein of greater than 3.5, and lipids, and either microscopic amount of blood or no blood. In nephritic syndrome, you see blood present in the urine with red cell casts, white cell casts, varying degrees of protein, which is usually not severe. But I should mention that it'll also be microscopic amounts of blood in the urine. glomerulonephritis is a major cause of nephrotic syndrome. And usually it's an infectious disease. Glomerulonephritis being very common, especially in children. Group A beta hemolytic strep. Most patients who get that do not have long-term sequelae of other causes of glomerulonephritis. But other infectious causes could be viral, hepatitis B, infectious mono, mumps, measles. And then multi-system diseases can cause glomerulonephritis like lupus, vasculitis, Henoch-Schönlein, purpura, and Goodpasture syndrome. Acute glomerulonephritis, in this we have inflammation of the glomerulus caused by primary glomerular injury. And the injury increases glomerular membrane permeability and reduces glomerular membrane surface area. So the result is a decreased glomerular blood flow, which results in hypoxia, causes further injury, a decrease in the GFR, and an increase in serum creatinine levels. And again, as I showed you in the slide with the algorithm, you have glomerular sclerosis or scarring, and that can lead to the effects of decreased kidney function. Acute glomerulonephritis clinical manifestations include hematuria with red blood cell CAS. So that can actually lead to smoky brown tinged urine, proteinuria that exceeds 3 to 5 grams per day with albumin. So you get a low serum albumin and edema. And then oliguria, where the urine output becomes less than 30 milliliters per hour. My last slide is a discussion of chronic glomerulonephritis. Glomerular diseases with progressive course that can lead to chronic kidney failure. And some of secondary causes are diabetic nephropathy, where there's podocyte injury, progressive thickening and fibrosis of that glomerular basement membrane, and expansion of the mesangial matrix. Lupus nephritis, another cause of chronic glomerulonephritis, is an inflammatory complication that involves an autoimmune syndrome and formation of autoantibodies against double-stranded DNA in the nucleosomes with glomerular deposition of the immune complexes that then lead to inflammation and further injury of the kidney.